Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Welcome back to the Dusty Muffins. Today we're talking about a group of women who can get completely lost in the menopause conversation. We tend to talk about menopause as something that gradually happens somewhere around your late 40s or early 50s. But what if you're 35 or 40? What if you go into hospital premenopausal and come out postmenopausal? Or chemotherapy, radiation, surgery, or another medical treatment suddenly changes your ovarian function. These women can be thrown into menopause with very little warning and sometimes astonishingly little information about what happens next.
Our guest today knows this from both sides. Julie Parana is an occupational therapist, certified women's health specialist, menopause coach, and the founder of the Menopause OT. She has more than 20 years' experience in rehabilitation in women's health, and her work now has a particular focus on women experiencing early surgical and treatment-induced menopause.
And this is personal for Julie, too. Following hysterectomy, she experienced surgical menopause herself and was postmenopausal at just age 42. So today, we're going to talk about what happens when menopause comes much earlier or much faster than expected, why hormone therapy is still underused in these women, what women should actually be told before surgery or treatment, and what good care should look like afterwards. So Julie, welcome to the Dusty Muffins.
Thank you so much for having me. I'm happy to be here.
Let's jump straight in, Julie. We'll start with you. Can you take us back to what happened to you when you were 42? What led to your surgery and what you were told beforehand about the hormonal consequences?
Sure. So I had a hysterectomy due to adenomyosis. I was experiencing all of the very unpleasant symptoms that accompany that. A lot of pain, very heavy bleeding. Sometimes I was bleeding up to 35 days consecutively. And it was really sort of destroying the quality of my life. And I really didn't have any use for my uterus because I had decided long ago that I didn't intend to be a mother. So I'd actually already had my tubes removed several years prior to that. So I had, talked to my doctor about my options. We decided to proceed with a hysterectomy. But I was told that my hormones would not be impacted because my ovaries were being left in. And so I was told that menopause would happen at the, quote unquote, normal time. And that made sense to me. So I had the surgery and, pretty quickly recovered. I felt great within a few, weeks of the surgery. I healed very quickly from that and I felt great initially. But then I started to experience a whole host of symptoms, but I didn't connect any of those symptoms to menopause because I didn't know what happens in menopause other than hot flashes and night sweats. And those were not my initial symptoms. My initial symptoms were really bad brain fog, word finding problems, memory lapses. I felt like I had ADD and I couldn't focus or concentrate. And I had never felt that way before. And I really started to freak myself out that I had early onset dementia because that does run in my family. And so I was like, oh my gosh, I need to go to a neurologist. I was freaking out about that. I started to have dizziness and vertigo. I was constantly breaking out into hives. I was developing allergic reactions to products I hadn't used for years. And I was just getting hives all over my neck and chest all the time. I had this ridiculously long bout of plantar fasciitis that I could not get rid of. And I'm an occupational therapist. I know how you're supposed to treat that. I did every single thing. I wore that stupid splint on my foot every night. I did all the exercises. Nothing was touching it. And so I was just like bouncing around to all these different doctors. I went to the dermatologist. Oh, I was also breaking out again. I was getting acne. So I went to the dermatologist. I went to the allergist. I went to an ENT for the dizziness. I went to sports medicine for my foot. And, every doctor just kind of looked at that symptom in isolation, and none of them connected it to menopause, and neither did I, until I started to get hot flashes. And they weren't even like severe, like profusely sweating. I just started to notice that I was like overheating a little more easily than I used to. And so that's what made me think, maybe my hormones were impacted, because then all of a sudden the light bulb went off and I'm like, wait a minute, all of these seemingly random symptoms, all of these started after my hysterectomy. And so then I asked if we could test my hormones, and even that took some convincing, because my doctor was like, oh, you're 42, you're not in menopause yet. And I'm like, well, I had a hysterectomy. I also had my tubes removed. Like, maybe we should check. And my estrogen was less than 15. So no wonder I felt so weird, right?
Wow.
And all I got was a message in my patient portal that said, you're postmenopausal, that explains your symptoms.
How long did that take?
And how far after your surgery was that?
Yeah.
So the symptoms, I would say the initial symptoms honestly started probably within a few weeks of the surgery, but up until getting that blood work, and it was close to a year where I was having all of these symptoms and like going to all these different doctors and trying to figure out what the heck it was. It was almost a full year after the hysterectomy where then I was diagnosed as postmenopausal, and offered no education, no guidance, no discussion on next steps, no offer of hormone therapy, even though I was 42, about a decade before I should have gone through menopause. And actually, even that message in the patient portal wasn't technically correct, because we had only had one blood draw. So we didn't know for sure that I was postmenopausal yet. So all the gaps in care that I experienced along the way up until diagnosis and after is really, what kind of inspired me to start my practice and to really like learn everything I could about menopause, first to help myself, because I didn't intend to spend the next 40 years of my life feeling like that. I figured there must be something I can do about this. There must be something I can do to feel better. And so I read and researched and studied everything I possibly could about menopause. And, I learned that replacing my hormones was absolutely essential. And so, I tried to find another doctor to help me with that. And then, of course, I had to make some lifestyle changes to really feel like myself again, too. So it was sort of a long process to get the diagnosis, and then lots of hoops I had to jump through along the way just to get the right care afterwards too.
Can you imagine a 40-year-old man being that sick and going to that many doctors?
Would never happen.
Finally having his hormones tested and getting a message through the portal, your testosterone's 15.
Yeah.
See ya.
Yeah.
Would never happen. And then when I did ask, I made an appointment, I made a follow-up with my primary care, and I asked, should I be replacing my hormones? And she told me she didn't believe in it. Those were her words.
The belief system. Oh, don't we love that one?
And at this point, I had done just enough research to know, to know that wasn't great. I said, well, I don't believe in getting early onset dementia and osteoporosis and cardiovascular disease and diabetes. Right. So let's, refer me to somebody else. And then the second doctor I went to told me that I wasn't a candidate because my mother had a history of breast cancer, which I also knew was not correct. And so it took me 3 doctors to finally find one that would treat me. And then even that doctor started me on the lowest dose patch 0.025, which now in hindsight makes no sense, because we knew I was making no estrogen. So like, why did we start at the baby dose? And then, we increased from there to the next. And then after, this is when I was starting to learn and realize most doctors aren't trained in this. Even OBGYNs don't know a lot about this if they haven't gone outside their training and educated themselves. And so when I was at the 0.05 patch and I still wasn't feeling, a ton of benefit yet, I had asked about increasing, and she was very reluctant to increase my dose from there. And then, that's when I started really to learn that, not only did I need hormone therapy, but I needed to be replacing my levels to like pre-menopausal levels. And I just, I felt like that wasn't going to happen on that dose. And so I found finally, my fourth doctor was, actually, he's a nurse practitioner who was menopause certified. And then finally, I was, in the hands of somebody who knew the dosing that I needed to be on, also knew I should be using vaginal estrogen, all of those things. And I just felt like, if I'm a healthcare professional and I have really good health literacy, it was this hard for me to access the right care. I can't imagine. And now I know, now that I do this work, I know how many women fall through the cracks, how many women are, either not offered hormones at all, or, they are told that they're not candidates when they are candidates, or they're severely underdosed. There's just so many barriers to care.
There's a lot of things that we're not trained well in. Like if you're an OBGYN and your patient comes to you and says, I have trigeminal neuralgia, can I talk to you about trigeminal neuralgia? And your OBGYN's like, no, that is not my wheelhouse. You need to go see neurology for that. They don't turn around to you and say, I'm sorry, I don't believe in trigeminal neuralgia.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, see-me, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
You should just go home and not look for any further care, because it's not a real thing. I mean, it's astonishing, the hubris when it comes to women's hormones. And astonishing.
And what's even more shocking now is that, here we are in 2026, and we've been ferociously talking about menopause, at least for the last 3 years, right? Since 2023. And that there are still providers who don't know, don't believe, just don't. And it's like, okay, it's time for you to retire. Like, you need some CE. It is your ethical responsibility as an OBGYN to be knowledgeable. Like, you can't be living in the 2001 data anymore. And for a woman, to have to go to 4 different providers is just lunacy.
And I think anybody who takes
especially
care of
for
women,
early menopause, I mean, there's very clear guidelines on that.
yeah, anyone who takes care of women, they need to be able to tell women where to go. They need to at least be educated so that they know where to tell women to find that type of care, whether it's primary care, internal medicine, OBGYN, urology, neurology, cardiology. Anybody that puts their hand on a female patient needs to understand midlife care. They don't have to take care of it or treat it, but they have to understand it in order to be able to get women where they need to go when they're crying for help or needing help. I just think it's just, at this time, there's no excuse.
Yeah. And I mean, if we're starting from a place where doctors can say, I don't believe in this, that's really bad. That's not like, oh, I didn't get good training. That's something on a completely different level. I don't believe in this.
Right. As if it's like Santa Claus.
Right. Exactly. Yeah.
And I was thinking about it too, like now having gone through this, it's like, would we ever take out someone's pancreas and tell them like, you know what, eat a low carb diet. And if that doesn't work, we'll give you like maybe a unit of insulin. Like that would never happen. We wouldn't remove a thyroid and tell someone, so why are we, now I understand in my case, my ovaries were not removed, but they did not get the memo that they could keep functioning.
One has to wonder
it's essentially the same
what
thing.
happened.
And it blows
One has
your
to
mind.
wonder what happened during that surgery, to be honest. A part of me is like, and this is like, you had already made it known that you did not want to have children. Did it not matter during the surgery about conserving those ovaries in order to make sure that they were still working post-surgery, to conserve ovaries and then to feel that way in, just a couple weeks, the way that you were feeling, right? Because I think, now they say it's 4 years for menopause in a woman with a hysterectomy and conserving their ovaries 4 years earlier than they would go in. It just is interesting, was there any carelessness or not when they were doing the surgery because they knew that you did not want to have children? I don't know. I'm just I'm just guessing. I'm just thought like, boy, you know.
Well, I have to think, if you had your tubes removed a few years beforehand, that was the initial insult, right?
Right.
Right.
That's what I was
Set up
thinking
the
is
blood
like blood
supply.
flow probably
Yes.
impacted because of the two.
But you didn't have-
Also, interestingly, I did learn after all of this happened, I didn't have symptoms. No, I didn't have perimenopause symptoms going into the surgery. Not that I was aware of, nothing like I experienced afterwards. That's for sure. I did learn later that some of my family members on my dad's side did go into menopause early. My grandmother and two of my aunts were postmenopausal by like 40, 42. So maybe I was heading that way anyway. And that was like the final, nail in the coffin. I'll never know. Like I said, I wasn't really experiencing any symptoms before the surgery. It happened pretty quickly afterwards. And, I certainly don't want women listening to this to think that if they're going to have a hysterectomy and their ovaries are being left intact, that this is going to happen to you. It likely won't happen to you. But menopause can come earlier than you expect it to. Like you were just saying, menopause having a hysterectomy, even if your ovaries are left in, it can impact timing and it can push menopause a little bit sooner. So I think, women need to know what the symptoms are so that when you start experiencing them, you don't do what I did and go to all these different doctors and trying to figure out what the heck is wrong with you. You'll get to your answer a little bit sooner and then you can seek treatment. I think if your ovaries are coming out and you're going into surgical menopause immediately, you absolutely need a plan. And in most cases, you should be waking up from that surgery with an estrogen patch on your body. And you absolutely, if you can't take hormone therapy, you still need to be offered a plan and what you're going to do. But if your ovaries are staying in, it's just a good idea to at least be aware that it can impact the timing of menopause, and then have your plan in place so you know how to address it when you do start experiencing symptoms, because you're not going to have your cycle to go by anymore. And that's not going to be able to help like when you're in perimenopause. Right.
There's even data out there that how you do the hysterectomy affects ovarian function and the blood supply to the ovaries. You can do it through a vaginal approach, or you can do it through a laparotomy approach. And even that has an effect on the blood supply to the ovaries. So if I, as a primary care doctor, know that, should the surgeon removing your organs not know that information, and give you a heads up?
I think most people are doing MIGs now, minimally invasive GYN, at least in 2026. I think that's pretty much, what most providers are trained, which has more conservation than the old methods that we used to do.
The opposite. It has more of an effect on the blood flow. So if you open up the abdomen, you can see really well what you're doing, and you're going to have less effect on the ovaries. But the way we do it now has more of an effect on the ovaries.
Oh, yeah, I hadn't heard that from surgeons before.
But to your point, the fact that the same surgeon that's trained to remove these organs is not also trained in how to treat menopause blows my mind. Like, how is that a thing? How are we training surgeons how to put women into menopause, but then we're not teaching them anything about how to manage menopause, or at the very least,
that it exists.
Even if they're not going to be the ones that manage these patients long-term, like they have to be able to at least give you the education that this is what is going to happen to you. And then here's the specialist you're going to follow up with afterwards to help direct your menopause care. Like that's not happening.
It all needs to be part of that pre-surgical.
It's surprising that
conversation that they have with you, right? That pre-surgical conversation before you open me up. You have to sit down and take the time, and your primary care provider should be doing it too, because you should be seeing them for their pre-op clearance. So both practitioners, you should have, sitting there and saying, this is what could happen. We're going to keep your ovaries, but there is a chance that this could happen. And this is what I want you to look for. This is what I need you to look for. So that way we can get on it and we can treat you. That would have been such a whole different conversation for you, and a whole lot less, bouncing around for you.
It would have changed a lot for me. Yes. Yeah. And I do want to say that, like, in my experience, my hysterectomy was 100% worth early menopause. I feel great now. Now that I'm replacing my hormones and I've made lifestyle changes, my body has no idea it's in menopause. I feel amazing. So I do want women to know that menopause doesn't have to suck, and you can feel better after you've gone through that. But you can't if you aren't given the right information, and you can't if you're not given the right treatment. And so, the trade-off was worth it for me. It just was unfortunate that it took all that time, and then, several doctors and a lot of advocating for myself and a lot of self-education in order to get where I am today. And so, my goal, is really to just help women know that this is a possibility. Also, hopefully we can get providers caught up to speed as well. I think we all are on our algorithms are showing us menopause nonstop because that's what we're interested in. So sometimes it's hard to believe that there's still physicians and clinicians out there who don't know anything about menopause, but they're not, on the same social media feeds that we're all on. So they're probably not, learning all of this the way that we are.
Do you get messages from people, Julie, saying they've had a similar story or that they've been told a certain thing by their doctor about hormone therapy?
All the time. And then I hear from women who are like, my ovaries were taken out 15 years ago. No one mentioned this. They were put into immediate surgical menopause. They were given no plan. I just heard from a woman the other day who had her ovaries, hysterectomy, all of it came out at 20 years old. She's now 42. No one ever brought up hormones with her. She finally just found a doctor that was menopause informed and was put on hormone therapy. And she's like, I cannot believe I feel like an entirely different person. Of course, she already has osteopenia because they checked that. She had a lot of metabolic dysfunction. She was diabetic, all of these things that likely could have been prevented. And it's malpractice that this happened to her. You can't just take someone's ovaries out. And she had no contraindication to starting hormone therapy. So it's really sad. Some of the stories I've heard are really awful and really sad. And also the underdosing. I hear about that all the time from women who are like, well, I'm on hormone therapy, but I don't feel better. And then you find out that they're on a 0.025 patch. Well, of course you don't feel better. That's a whisper of estrogen. You're not making any. That's just not going to be enough.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
It's getting harder and harder to condone this because the data is there. We have all the data. We have the guidelines from the North American Menopause Society. If a woman goes into early menopause, premature ovarian insufficiency, surgical menopause, you replace her hormones at least until the age of natural menopause, which in America is around 51. So it really is malpractice.
It absolutely is. And then I also hear from the women who, even if they've found a clinician that is willing to prescribe the hormone therapy to them, they're afraid to take it. They're afraid to take it because we have convinced women that hormones that their bodies naturally produce are suddenly trying to kill them once they reach midlife. And I don't know how the heck we did that, but when you really sit down and think about it, it's totally absurd to think that your body has made estrogen your whole life and suddenly it's dangerous to you because you had surgery or, it just doesn't make any sense. And so, that's another huge barrier is that, we have so much damage that was left by the WHI that we still have to undo that, because even when you get the prescription and you have it in your hand, so many women send me messages that they're afraid to take it.
Yeah. What did it do to you psychologically, or what do you think it does to women psychologically who are told over and over again, there's nothing wrong with you, you're fine? When
you do start to help. You do start to think you're going a little crazy, or am I making this up, or is it worse than it really is? And I think part of the reason that I didn't really investigate, I wasn't taking this super seriously in the beginning, all these little symptoms I had, they didn't seem like big deals to me. And, I work in acute inpatient rehab as an OT. I'm helping people recover from spinal cord injuries and strokes and amputations and these severe life altering events. And so I'm like, oh, I have plantar fasciitis. Oh, I have hives, I can't feel too sorry for myself. So these little symptoms over time, they were easy for me to dismiss as minor inconveniences. And it wasn't until they all piled on kind of at the same time that I was like, wait a minute, this can't be right. And then that's what made me sort of investigate it a little bit further. But as women, we kind of dismiss our symptoms, we normalize suffering, and we shouldn't do that.
Yeah. And I think just to your point again was, when women are taking their prescriptions and then they don't take them, it's because the conversation wasn't enough that they had with their practitioner, right? I mean, if you are really putting in that time to educate your patient on why you're taking estrogen, what it does, what it doesn't do, the side effects, what progesterone does or what testosterone does, I think for most of us, prescribers here, there's not very many women that don't put that ding patch on or not run into the store to go get their medications. If we've done that job of actually taking the time, but that's also the problem, is that most practitioners don't have that time to do it in your normal, employed position.
Absolutely. Yeah. The 10-minute, 15-minute doctor's visit is not enough to cover all of that. And that's another reason why I started my practice. Is I can't prescribe hormones to anybody, but I can educate and I can sort of fill that gap that 10-minute doctor's visit isn't going to give you, and, help you come up with your menopause plan, help you understand what all of your hormonal and non-hormonal options are if you're not a candidate, or if you just simply don't want to replace your hormones. So at least going into these appointments what your options are, and then also, of course, the lifestyle piece, because hormones is one part of the equation, but our lifestyle is also so important. We really need a holistic approach to managing menopause.
So Juliana, for the women that maybe hormone therapy is contraindicated, how does OT, what can OT bring to menopause care that maybe we haven't thought about?
So really what I'm helping women do is implement all the lifestyle pillars. We work on mindset and nervous system regulation, sleep hygiene. We work on stress management, nutrition, and movement. But, what I'm really helping my clients do is implement these lifestyle changes gradually over time, because most women know what they should be doing, but if I could give you a list of 25 healthy habits that are going to help you feel better, you're not going to do all of those. So, it's just helping you gradually implement them. And, as an OT, I look at how is menopause impacting your day-to-day life? How is it affecting your roles, your routines, your relationships, your work performance? And then we build a plan to how you're going to get that back. What are the highest leverage changes that you can make first, and start there and then build slowly over time. And also it just gives you a person to have in your corner, someone to help you troubleshoot when roadblocks and obstacles come up, someone to be accountable to. You get a partner in all of this. You're not just handed a protocol, you get someone that's helping guide you through it.
What does a patient look like that needs nervous system regulation, and what is the easiest thing that patients could do to help with that nervous system regulation?
Honestly, I think we all need it. We just don't realize it.
It's true.
If you had asked me 5 years ago, what do you do to regulate your nervous system? I would have rolled my eyes at you. I wouldn't even know what that meant. I would have thought it was woo-woo and silly. But really, our hormones regulate our nervous systems for us quietly in the background. We're on autopilot and we don't have to think about it too much until we're in either the chaos of perimenopause or you're, without your hormones at all, post-menopause. And even if you're replacing your hormones, we still need to give our bodies a little help with that. And so we're just trying to, move ourselves from that fight or flight, always on, to the more rest and digest, calming stage. And there's so many ways we can do this. And I think, a lot of women think that they have to do breath work for an hour or meditate for, forever. And then they just don't really implement these strategies because they think they don't have the time, but it could literally be 10 minutes. It doesn't have to be, a huge practice that you're doing every single day. 10 to 15 minutes of breath work, I do a Tai Chi flow every morning when I wake up. I love that for my nervous system regulation. It can be meditation. It could be listening to an app. It could be getting light in your eyes in the morning. It could be snuggling your pet. It could be calling a friend on the phone. It's really any of those things, truthfully, are nervous system regulation. Anything that you're giving your body, the signal that it's safe and some time to kind of quiet everything else that's happening around you.
That is awesome. And I think you're right. Most of us probably need it and we just don't know how to do it. So
yeah, Yeah. I mean, I never thought of it before, and I'm an OT. And that really honestly never occurred to me that I needed to regulate my nervous system. But now I see how important it is. And
No, probably because they're so dysregulated all the time. We think that's normal.
yes. Yeah. And we think like we're so used to just being productive every minute of the day. We think that, at every moment of the day, we need to be doing something that's productive. And, a lot of what I'm helping women do, in addition to the nervous system regulation piece, is just like learning how to say no to things, learning how to delegate tasks, stop trying to be everything to everybody, creating some white space in your day, some like genuine time for rest and recovery, because most of us are terrible at doing that. So often before we're even adding on additional like healthy habits, we're doing that first. We're like clearing some space so that you actually have the time to start implementing those things and start taking care of yourself a little bit more, because unfortunately women often put themselves on the bottom of the list, especially if they're mothers and they have, they have a job and they're taking care of their spouse and they're taking care of their elderly parents, and, they get put to the bottom of the list. And truthfully, one of the reasons I think I was able to come out of this feeling as well as I am is that I don't have children. I'm not married. I had all the time in the world to figure this out. I've always been able to prioritize my own health. And so, I know not everybody has that, but I do encourage women to put themselves at the top of the list. And when you are entering this perimenopause, menopause, postmenopause age stage, it really is time to, if you haven't already, it's really time to start prioritizing your health.
Have you been told your labs are normal, but yet you still feel exhausted, foggy, and gain weight simply by looking at a meal? Well, you're in good company. In midlife, normal isn't enough. You deserve to feel like yourself again. I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and certified menopause specialist. I deep dive into the areas often overlooked: hormone optimization, thyroid health, gut health, medical weight loss, including administering testosterone therapy for women. No rushing, no insurance hoops, just a blueprint back to a vibrant life. I'm accepting new patients in Virginia, Florida, and 5 other states. Book your clarity call at www.christinehartkressdmp.com.
Another thing that gets forgotten about is women's sexual health when they enter early menopause, right? For whatever reason.
Absolutely. Yeah. Especially, if it happens surgically, and often, a hysterectomy can have major impacts on sexual health as well. And many women are not properly counseled about those impacts.
Do women talk to you about that, Julie, or do they tend to just talk more about the other physical symptoms and the brain symptoms?
They do. It is part of my intake form, because I think you have to ask the question to open it up, because people may not feel comfortable bringing it up right away. So, but if you directly ask the question, then you get, then they can, they prioritize, they kind of rate all those areas. And so I ask it, and it's often on the list of things that they would like addressed. Because
I know. And it's like we were saying earlier, you don't have to fix everything, right? But you can draw attention to it and say, hey, this is obviously something that is bothering you or a problem at the moment. And there are people who can help with this, and guide them. Yeah, you don't have to know everything or fix everything.
And just helping normalize it too, because, sometimes women just feel like there's something wrong with them. I have a lot of women who like have never even heard the concept of like spontaneous desire and responsive desire. And even just explaining that and like letting them know that responsive desire is normal, then they're like, oh, okay. Like that's just, they haven't heard that before. And they, maybe that they've changed and, how their preferences are now. And so they may feel, upset about that. And then, even just having that little bit of knowledge, knowing that this is normal, that can, definitely help.
Yeah. And then, there's the women who are in treatment-induced early menopause, like the women going through cancer treatment, and their oncology team is focused on, treating their cancer, but then women are dealing with hot flashes, insomnia, as a result of their ovaries going into an early retirement. And, what would you want every oncology team to say to a younger woman before treatment that could affect ovarian function?
Well, I think just knowing that, I think a lot of women in that situation are told that their ovarian function may be impacted, but usually it's really only brought up as terms of like fertility. That's only like the only way they're really thinking about it. I don't think they're really fully comprehending all the menopause symptoms that may come into play. And I don't think they are really fully prepared for all of the consequences of, losing their hormones. And so, we definitely need to be doing a better job managing those patients as well. Their quality of life after their breast cancer treatment, if we are putting them on hormone blocking medications, they absolutely need a plan to manage the hormonal aftermath of that. They need to be on vaginal estrogen, for crying out loud. I did a support group. I recently was asked to lead a support group for women who were navigating menopause after breast cancer, and none of them, there were 13 women on the call, not a single one of them was using vaginal hormones. And that just made me so upset, that, we still have a really long way to go to educate our oncologists that vaginal estrogen is safe for these women.
Quality of life, not just quantity.
Yes.
We're so focused on quantity. It is so important to also, what is the point of saving a woman's life if the life she is left with, she feels is not worth living?
Yeah,
absolutely. So and don't we even have studies that show that the vaginal estrogen does increase their
survival?
Yes.
Yeah. One question I had too is when we think about menopause and it's, becoming more publicly talked about, thank goodness, not enough, but it's a good start. We typically think, or I think most think of like your late 40s, 50s, even into your 60s are menopausal women. So do you feel like women who are in early menopause or premature menopause or surgically induced earlier than, let's say even 50, do you feel like that they feel left out of this movement, or how can we make that all encompassing so everyone's feeling a part of this?
Yeah. So it's funny, when I first started posting like a little bit about my story and everything, I'm 46 now. I was 42 then. And there were a lot of comments in my posts like, what do you know about menopause? You're too young. Come back to me when you've gone through it, all that, people who didn't know like my whole story. And, I was like, well, actually I've been postmenopausal for a bit. So, I think everyone attributes menopause as like something that happens to old ladies, right? That's why so many women in perimenopause has the symptoms, because you're not expecting it to start happening when you're in your 30s or your early 40s. But especially, and I have a client right now that I'm working with who has POI. And one of the things we're working on is she just feels in like such a different stage of life than her friends. Like they're, getting married and thinking about having babies and, or they're pregnant and she just knows that's not her path. She's like, I'm dealing with like hot flashes and the fact that I have osteopenia because she went through a ridiculously long time before she got properly diagnosed. So she is already osteopenic, and, there is, a part of her that feels just like she doesn't relate to a lot of, the conversations that her friends are having. And, so that can really take a toll on you, on your identity and, how you feel about yourself.
Big time. I have one last question. Oh, sorry.
I was just going to say, just for our audience, POI is premature ovarian insufficiency. And that's menopause that occurs before the age of 40, and it's in about 1% of the population. So just for orient everybody in case they are not oriented to that.
Yes. And in her case, she was experiencing symptoms of that probably as early as like her early 30s, like around 30 years old, but it took so long for her to get diagnosed because she was told those missing periods were normal. She, all her symptoms that she was experiencing were like, oh, that's just, some women have periods like that. And that's very unfortunate. It took a very long time for her to get, obviously she already has osteopenia, so she was probably estrogen deprived for quite a while.
One last question. There is a woman out there listening to this today who is coming up to her surgery. She's having her ovaries removed or her tubes removed or a hysterectomy. What would you like to say to her? What advice would you give her?
I would just tell her to have a plan, know the symptoms. So if your ovaries aren't coming out, at least know the symptoms so you can prepare yourself if you start to experience them. Know that menopause can come early, that, even if it's just your tubes coming out or it's just your uterus coming out, that doesn't mean your ovarian function is 100% spared. It usually probably won't happen immediately like it did for me, but it may come sooner for you. And so you want to have a plan in place. And if your ovaries are coming out that day, I would not go into that surgery without knowing exactly what your plan is. I would ask your surgeon, how are we treating this? Yep. The wait and see approach is totally not acceptable. So many women are told, well, we'll wait and see how you feel. If you don't feel well, we can start you on hormone therapy, especially if you have not gone through menopause yet. I mean, it might be a different conversation if your ovaries are coming out when you're 65. But if you have not gone through menopause yet and you're going into that surgery, you absolutely need to know what your plan is before you are rolled into that operating room. You need to know what your plan is.
Unless you're having your ovaries removed for a few particular types of estrogen sensitive cancer, then you should be leaving that operating room with a patch on your belly and your testosterone and your progesterone at home in the cupboard.
Yes, agreed.
I know. That's utopia.
Yeah.
Yeah, that's where we're headed. That's our goal.
That's our goal.
Yeah. Well, and like you said, it's misogyny that it's not what's happening, because in no world would we be, cutting off a man's testicles and not giving them a plan to manage that afterwards. It would simply never happen. So somehow we have just tied these hormones to just their reproductive value. That's and right. They do so much more than that. And I think that's the other reason that women miss all of this, is because most doctors don't even know that, let alone the average woman. They have no idea all of the roles that these hormones play in our bodies. And so, they think, well, I don't need them for pregnancy anymore. So it's okay if I don't have them. But that's simply not true. These hormones have many, many roles in all systems of our bodies. And you should be replacing them, especially if you are entering menopause early and you don't have a contraindication.
Absolutely. I think this is such an important conversation because, women should not have to accidentally discover the healthcare that they needed years later. Like the woman that you were talking about, and, getting someone safely through surgery or cancer treatment is obviously enormously important. But that's not where healthcare needs end. Women deserve to know what is happening to their bodies. And Julie, why don't you, to improve their quality of life. So Julie, tell everybody where they can find you and learn more about your work.
Sure. So my website is themenopauseot.com. And I'm also the Menopause OT on TikTok and YouTube and Instagram.
And we will include those details in our show notes. Thank you so much for joining us, Julie. And to everyone listening, thank you for spending time with us. We'll be back with another episode of the Dusty Muffins very soon.
Thank you for having me.
If you enjoyed today's episode, please take a moment to follow, subscribe, rate, and review the Dusty Muffins wherever you get your podcasts.
Those ratings and reviews might seem like a small thing, but they help us reach more women who are sitting at home wondering if they're the only ones struggling with hot flashes, brain fog, sleep issues, weight changes, low libido, anxiety, or all the other delightful surprises that hormones can throw our way.
Share this episode with a friend, your sister, your partner, your colleague, your mother, or that woman who keeps saying she's fine while surviving on caffeine and sheer determination.
The more we talk about these topics, the more women realize they're not alone and they're not imagining it. There are often solutions available.
Until next time, take care of yourselves, take care of each other, and remember, life may make us dusty, but we're not done rising yet.